The Less Invasive Stabilization System, DF, called LIS for short, was developed for the fixation of distal fractures of the femur. The LIS DF is an internal fixator which is pre-shaped to the anatomy of the distal femur. The screw positions on the device also take into account the anatomical characteristics of this region. The screws of the LIS are inserted monocortically. They are self-drilling and self-tapping and create a radial pre-loading in the bone. The angular stability of the system is obtained by a precisely fitting thread connection between the head of the screw and the LIS itself. The LIS DF plate is manufactured from a wrought titanium alloy. It's available in 3 different lengths, with 5 holes, 9 holes, and 13 holes in a left and a right version. The LIS screws are available in the 26 mm length for the region of the femoral shaft and 40, 55, 65, 75, and 85 mm lengths for the metaphyseal region. The screw hole insert can prevent the growth of tissue into the holes in the plate. Needed for assembly of the partly radiolucent insertion guide are the fixation bolt, the stabilization bolt, a drill sleeve, and a pin wrench. First, the fixation bolt is placed into the insertion guide through the central hole A. The insertion guide is fitted onto the distal end of the LIS plate by means of a 3-point fastening, and the fixation bolt is screwed in. The connection is stabilized by tightening the nut of the fixation bolt, first by hand and then with the pin wrench. To increase the stability of the connection, an additional stabilization bolt is inserted through a drill sleeve in hole B. To help in the reduction of distal fractures of the femur, the knee should be placed in flexion in order to relieve the tension of the gastrocnemius muscle. The positioning must allow radiological examination in both planes. This can be achieved either by raising the other leg so that it can be approached from the side, or if possible by lowering the other leg from the hip. For extra-articular fractures, a skin incision is made from Gerdy's tubercle about 80 mm in the proximal direction. The iliotibial tract is split. The space between the vastus lateralis and the periosteum is opened. The internal fixator can be inserted into the space between the periosteum and the muscle. The following instruments are required for application of the LIS. 2 280 mm long Kirschner wires with threaded tip, a trocar, and a drill sleeve. It's important to cool the screw during drilling with saline solution through the drill sleeve. Also needed are the pulling device, a screwdriver shaft, and the torque-limiting hexagonal screwdriver. The exercise is carried out on the intact femur where the supposed fracture is situated supracondylarly and can be stabilized with a 9-hole LIS plate. In a clinical situation, it's important for a good reduction to be performed and maintained before the LIS is applied. The LIS plate is guided through the surgical approach onto the distal femur and slid in the proximal direction, epiperiosteally beneath the vastus lateralis muscle. The exact position of the LIS plate is aligned with the condyle of the femur. The LIS plate comes to rest flat and a little anterolaterally on the condyle. After the LIS plate has been inserted, the stabilizing bolt is taken out of hole B and placed in the last hole of the LIS plate through a stab incision. The drill sleeve is secured by tightening the lateral screw on the guide. After removing the trocar, the stabilizing bolt is inserted and tightened, first by hand and then with the pin wrench. The list plate, together with the insertion guide, now forms a stable frame. The list plate is again aligned accurately on the shaft of the femur and fixed with 2 long K-wires. The list plate must be securely positioned on the lateral face of the femur. Before the next stage, it's essential that the position be checked in both planes. Before the first screw can be inserted, the distance between the femur and the list plate has to be fixed with the pulling device. For this, the pulling device is inserted through a drill sleeve monocortically. The drill sleeve is removed. The device is tightened by means of a knurled nut. If the pulling device is not used, there's a possibility that through the direct insertion of the self-drilling screw, the fragment may be dislocated and fixed in the medial direction. However, the pulling device can also serve as an aid in the reduction of the fracture by pulling a fragment onto the list plate and securing it in this position. Alongside the pulling device, the first 26 mm shaft screw is inserted monocortically. The self-drilling screws are placed on the screwdriver attachment, inserted with the drill, and then tightened with the torque-limiting screwdriver. This prevents the screws from jamming due to too much torque, which would make it difficult to remove later. While only 26 mm long screws are used in the region of the shaft of the femur, the lengths of the screws for holes A to F on the distal insertion guide are defined through the maximum width of the condyle. The width of the condyle can be determined either by means of an X-ray and the magnification factor of the X-ray, or during the operation. In this example, the width of the condyle is 90 millimeters. As seen on the instrument set, the lengths of the screws are determined by the true width of the condyle. Here, the third section is used. Alternatively, the lengths of the individual screws can be defined with the following instruments: a 280 millimeter K-wire, a guide sleeve for K-wires, a drill sleeve, and a direct measuring device for K-wires. The drill sleeve and the guide sleeve are inserted into hole D. The K-wire is placed in position. The length of the projection of the K-wire is read on the measuring device. In this example, the screw length is 65 millimeters for hole D. The 65 millimeter list screw is inserted. The filled screw holes can be marked on the insertion guide by the plastic stoppers. Other screw holes in the region of the condyle are filled until at least 4 screws are positioned securely in the distal fragment. A minimum of 4 screws are to be positioned in the main proximal fragment. When at least 2 screws are securely anchored in the shaft, the pulling device can be removed and a screw inserted. For the insertion of the most proximal screw, the K-wire and the stabilizing bolt have to be removed from hole 9. The locking bolt is loosened in order to remove the insertion guide. The K-wire is removed. The central hole, A, can be used for either a screw hole insert or with a regular screw. The insert prevents tissue from growing into the hole, so that the insertion handle can be securely remounted for a later removal of the implant. Alternatively, a screw can be inserted in the same direction as the previous K-wire. Fixation of a supradiacondylar fracture of the femur with 2 cancellous lag screws and a 9-hole Liss plate. For intra-articular fractures, an anterolateral arthrotomy, which provides good control of the reduction, is recommended. This arthrotomy also accepts the subsequent insertion of the fixator and can be used to insert lag screws from medial. The incision is close to the lateral margin of the patella. The lateral retinaculum is also incised at the same distance from the patella. The rectus and the vastus lateralis muscle are split. The fracture is a simple diacondylar fracture. The following stages of the operation are demonstrated on the bone model without soft tissue. First, in all intra-articular fractures, the joint block is reconstructed, and then in the second stage, aligned and fixed onto the shaft. The safety zones of the distal femur are shown. Ideally, they should be used to place lag screws so that there is no contact with the Liss screws. These zones lie either ventral, ventrodistal, or dorsal to the later position of the Liss plate. Here once again, the possible positions of the screws are shown on the bone model. In the C1 fracture, 1 ventral and 1 dorsal position for the lag screws are used. The reduction of the joint block is first secured with 2 centrally placed K-wires. Two 6.5 millimeter titanium cancellous bone screws with a 32 millimeter thread serve as lag screws. For their insertion, these instruments are necessary. Pre-drilling with a 4.5 millimeter drill bit parallel to the level of the ventral condyle. Cutting of the thread and insertion of the cancellous bone screw. When both cancellous bone screws are in position, the K-wires can be removed. Now the joint block is aligned to the shaft. For easier orientation, a K-wire can be placed parallel to the joint line. It's important to have a good reduction before application of the Liss plate. In this exercise, it's fixed temporarily with 2 crossed-over K-wires. An external fixator applied anteromedially can also prove to be a very useful intraoperative aid in the reduction of the fracture. When placing the K-wires, the later position of the Liss plate has to be taken into account so that the K-wires do not interfere with the introduction of the Liss plate. The Liss plate can now be slid through the parapatellar approach under the vastus lateralis muscle and along the femur. The position of the Liss plate is secured with 2 long K-wires with threaded tip. The drill sleeve for the pulling device can now be inserted through the insertion guide. In the soft tissue model, a stab incision is made at the level of the corresponding hole and spread with a forceps. The drill sleeve with trocar is inserted until the clamp ring of the drill sleeve engages on the guide. The trocar is removed and in this case the pulling device is drilled in. The drill sleeve is removed, and the distance between the shaft of the femur and the list plate is fixed by tightening the knurled nut on the pulling instrument. A 26 mm screw is inserted alongside the pulling instrument, and the filled hole is marked on the insertion guide with a plastic stopper. After the corresponding lengths have been determined, screws can be inserted directly into the distal fragment. However, because there is a possibility that the list screws will collide with the cancellous lag screws, the holes should be pre-drilled in the corresponding direction of the screws. For this, a long K-wire can be inserted through the guide sleeve in order to detect a possible collision with a lag screw in good time. If the K-wire is inserted without problems, the screw can be safely positioned. The reduction K-wires can now be removed. Now the other list screws are inserted as already demonstrated. It should again be pointed out that at least 4 screws per main fragment must be securely anchored in the bone. The insertion handle is removed by loosening the fixation bolt. The K-wire is removed. Finally, the central hole, A, is filled with a screw hole insert. With the appropriate alignment, the list plate is positioned well on the lateral distal femur without causing irritation to the soft tissue. List periprosthetic screws. The List system is also suitable for the treatment of periprosthetic fractures. If the fracture is treated while a prosthetic shaft or an intramedullary force carrier, a nail, is in place, specific short screws are available for the application of the list plate. The gold-colored screws are available in lengths from 14 mm to 18 mm. Unlike the regular blue screws, they do not have a drill tip, so that drilling before inserting the screws is necessary. The 4.3 mm drill bit with the corresponding 7.2, 4.3 drill sleeve is used. A drill depth of 14 or 18 mm is possible. Then the corresponding screw is inserted through the trocar.